Imagine this. It's late. You get that call from the ER. Polytrauma patient just rolled in. And they need you to assess a complex facial fracture. Where do you even start? Welcome to a really crucial deep dive, especially for you plastic surgery residents out there. We're tackling the intricate world of facial trauma today. We pulled together some foundational texts covering, well, pretty much everything from causes to surgical details and managing those tough complications.
Yeah, and our mission today is really to distill the most vital clinical knowledge, those practical pearls from this stack of sources. We want to equip you with, truly actionable insights for surgical decisions, patient management, and yeah, even getting ready for those board exams. The goal is for you to be not just informed, but really well-informed, confident when these challenging cases come through the door.
Exactly. And to do that, we're drawing from several key articles. We got facial fractures, frontal sinus fractures, mandible fractures, orbital floor fractures, zygoma fractures, and even a fascinating guide, How to Block the Face. Gives us a really holistic, practical view, I think.
Absolutely. A good spread.
Okay, so let's dive in. First big theme, the landscape of facial trauma. Causes, assessment, general principles are sources that consistently point to assaults and motor vehicle collisions, MVCs, as the main culprits for well over 50 years now.
Right, and what's really interesting is the pattern, Despite safer cars, MVCs are still big predictors of panfacial trauma, high energy, multiple fractures. Assaults, on the other hand, they often lead to more isolated fractures. Lower energy, usually just one area.
Makes sense.
And then, of course, you've got falls, sports injuries, work accidents, and unfortunately, gunshot wounds, too.
And it's rarely just the face, is that those concomitant injuries are so common, you really need that trauma team approach. It's easy, I imagine, for residents to get tunnel vision.
That is exactly the trap. And the real pearl here is pushing past that initial obvious injury. You've got to think like a detective, hunt for those silent, confident injuries, especially in polytrauma. Missing them isn't just an oops. It can lead to significant long-term problems for the patient.
So that initial assessment is critical.
Absolutely critical. High-resolution, fine-cut CT scans are essential, and you need a clear plan for well-timed surgical intervention. Early detection of all related injuries, that's paramount for preventing those late, nasty complications.
Our sources also talk about how management principles have evolved. What are some of the key shifts we've seen?
Oh, quite a few. Changes in fixation principles, the timing of repair, our understanding of biomechanics, the materials we have now. But the big goal, that stays the same. Accurate clinical and radiological assessment. That's the foundation for planning and executing the repair to get the best long-term outcome.
Okay, let's start our journey through the face, right at the top. Craniofrontal fractures. These seem particularly complex, maybe even a bit intimidating for residents.
They can be. Frontal sinus fractures, they make up about 5 to 15% of maxillofacial fractures. The complexity really hinges on, well, how far things extend. Are the anterior or posterior tables involved? Is the duroton narrow? And crucially, what about the frontonasal duct, the FND? And a point here about the FND, don't just picture a simple tube. It's often more like a recess, intricate anatomy, and that makes it really vulnerable, even to minor trauma. If it's compromised, your surgical plan gets way more complex.
So, for a resident, what are the red flags?
A CSF leak, that happens in about 20% of cases, or any FND injury, those will drastically change your plan. You'll likely need a multidisciplinary team, maybe neurosurgery, maybe ophthalmology, and always let a glabella hematoma or a cut right there raise your suspicion immediately for a frontal sinus fracture.
Exposure seems key here. What are the go-to approaches? Any common pitfalls?
Good question. Yeah. Adequate exposure is everything for symmetry and access. The coronal incision, that generally gives you the best view. You can even treat intracranial trauma through it if needed. And you'll routinely elevate a pericranial flap with that approach, a pitfall. Trying to get by with smaller incisions or just using existing lacerations, it often just compromises your view, leads to incomplete reduction, worse outcomes. Now, with anterior wall fractures, if they're undisplaced and the FND is okay, you actually don't always need to operate right away. But the key is aggressive antibiotics and long-term follow-up, yearly CTs, because late infection, it's a real silent threat.
And if that anterior wall is displaced,
then yeah, you need surgical correction. Restore that contour, you'll remove the fragments, note their position, check the posterior wall, check the FND. If everything else looks good, remove damaged sinus mucosa, then reconstruct the anterior table. Microplates, mini plates, maybe titanium mesh. You can address minor contour issues later. And here's a practical tip. Think about using resorbable plating systems. They avoid palpable hardware later and don't cause artifact on follow-up CTs. Could be good for younger patients especially. Endoscopic repair for simple fractures it's gaining traction, avoids the big flap, but its role in complex cases, exploring the FND or posterior wall, that's still being figured out.
Okay, this is where it gets really tough decision-wise. What if the FND is involved, or the posterior wall is badly fractured?
Exactly. If the FND is injured, or you have a displaced posterior wall fracture with a dural tear, maybe CSF leakage, then you're looking at either sinus obliteration or, less commonly, cranialization. Obliteration, think of it like a deep clean. You have to meticulously strip all the sinus mucosa. You use a high-speed burr, really get into those little nooks and crannies where mucosa hides. Miss a bit, you're asking for trouble later. Then you plug the FND, pericranial graft, bone chips, fibrin glue, those can work. But the author's preferred technique, especially if it's contaminated, is a galeal frontalis myofascial flap.
Why the flap specifically?
Because it's living tissue, it's vascularized. That gives it excellent resistance to infection, which is huge in trauma. Then you rebuild the anterior wall, leaving a little gap for the flap's pedicle. Cranialization, that's a bigger deal. Combined neurosurgery procedure, they remove the whole posterior wall, plug the FND, repair the dura. The brain's frontal lobe is expected to fill the space. It's usually reserved for cases where neurosurgery is already indicated.
So that vascularized galeal flap, it really sounds like a game changer for those contaminated fields, a living barrier.
It absolutely is. Compared to, say, an avascular graft that might necrose or get infected easily, the galeal flap is robust. It resists infection much better, super critical in these dirty trauma wounds. Complication-wise, for frontal sinus fractures, the main things to watch for are late mucosal formation, sometimes years later, chronic headaches, contour issues, meningitis, brain abscess. Those are devastating, but thankfully rare. Long-term follow-up, yearly CTs for at least 5 years, that's what the sources recommend to catch things early.
Okay, let's move down. Central midface, the naso-orbito-ethmoid complex, the NOE. But it's incredibly challenging to reconstruct, especially given how central it is visually.
It really is. Reconstructing the NOE, it starts with good exposure. Usually a coronal flap from above, maybe the lower eyelid incisions, or an upper buccal sulcus approach from below. The absolute key is meticulously identifying and preserving where the medial canthal tendon inserts into that central bone fragment. That's crucial for function and looks. And for residents, Markowitz's classification is super helpful. It categorizes NOE fractures based on that central fragment, and that directly tells you how much exposure you need in your fixation strategy.
Can you give us a quick rundown of those types?
Sure. Type I is a single stable piece, pretty straightforward reduction, rigid fixation, often 3 miniplates. Type 2, it's comminuted, broken into pieces, but the little piece of bone holding the tendon, the MCT, is intact. Here you need sequential reduction, maybe inlay bone grafts, and often transnasal canthopexy wires. Got to place those carefully, posterior and superior to the tendon to stop it rotating outwards. And then type 3 is the toughest. The central fragment is comminuted and the tendon is torn off or avulsed. That absolutely requires a formal medial canthoplasty.
With all that comminution, is there a specific repair sequence residents should follow?
Yes, definitely helps keep things anatomical. Work deep to superficial. First, kind of move the nasal and nasomaxillary bits laterally to see the medial orbits clearly. Reconstruct the medial walls, then reduce and fix the central segments, then address the nasal bones themselves, restore that dorsal projection. Primary bone grafting, often needed for unstable, comminuted injuries. To bridge gaps, rebuild the medial wall for the tendon attachment, or get that nasal bridge height back.
And getting that medial canthus right must be critical for how the eye looks.
Oh, it's the single most important step for restoring the patient's normal appearance. In type 3 injuries, you have to specifically recreate that bony insertion point. The rebuilt medial orbital walls give you the foundation. You want the tendon insertion high up on the posterior lacrimal crest. Get the depth and vertical position just right. Surgical insight here. The classic method is transnasal stainless steel wire. Very stable. But you could also consider ipsilateral bone anchors. Avoids dissecting the other side, maybe less wire stretch.
What about the nose itself, after all that trauma?
Now, if the bone segments are decent and the septum's okay, open reduction and internal fixation might restore dorsal projection. But if it's collapsed or bone is missing, you'll likely need cantilever bone graft reconstruction. That takes careful planning, get the graft length right, stabilize it well from the glabella, and really watch that nasofrontal angle for a natural profile.
And the soft tissues around there, they seem like they could cause problems later.
They absolutely can. Soft tissue redraping is tricky. Post-op swelling, maybe a seroma, can lead to permanent thickening, loss of definition. You can control this pretty effectively with external bolsters. You secure them with transnasal wires, helps adapt the skin and soft tissue nicely to the bone contours while things heal. Resident takeaway. Common issues after NOE fractures. Contour problems, nasal deformities, crooked nose, flat bridge, and those periorbital soft tissue things like the canthus being in the wrong spot, dystopia, or the eyelids looking uneven. Got to prevent and manage those carefully.
All right, moving laterally now to the orbit. That delicate pyramid protecting the eye. What are the common fracture patterns, and how does understanding how they happen help us?
Yeah, we mostly see blowout fractures, usually the floor, sometimes the medial wall, and impure ones that involve the rim, too. Understanding the mechanisms, the buckling theory, where force on the rim travels to the floor, versus the hydraulic theory, where globe pressure directly breaks the floor, helps explain the different fracture shapes we see. And a huge clinical pearl. Watch out for trapdoor fractures. Pure floor fractures, usually in kids, where a hinged piece of bone traps orbital contents, then snaps back. Usually traps the inferior oblique or rectus muscle, leads to that classic restricted upward gaze and diplopia.
What signs scream urgent orbital problem?
Okay, key signs. Pain, diplopia, bruising around the eye, swelling, blood in the white of the eye, numbness in the cheek or upper lip area in orbital nerve. Critically, you must assess for anaphthamos, the eye sinking back. More than 2 millimeters is significant. And hypoglobus, the eye dropping down. Remember, just a 5% increase in orbital volume can cause noticeable anaphthamos. And the eye exam itself, absolutely critical. Visual acuity, color vision, especially red saturation loss, that hints at optic nerve trouble and pupillary responses. Check for an APD if the patient's unconscious. Force duction test, non-negotiable. Got to check for muscle entrapment. Urgent indications for repair, think 24-48 hours. Early anaphthamos, 2 millimeters. Big defects, 2 centimeters. Those predict delayed anaphthamos. Pediatric trapdoor fractures, a white-eyed blowout with minimal external signs, but severe entrapment, and that strong oculocardiac reflex. And any CT proof of entrapment with symptoms like diplopia, gaze restriction, or that non-resolving oculocardiac reflex, bradycardia, nausea, vomiting from vagal stimulation that needs urgent attention.
Okay, but sometimes we can wait a bit, let the swelling go down.
Yes, if none of those urgent signs are there, you can follow it up within maybe 2 weeks. Persistent diplopia in the central gaze or an ophthalmos showing up later within 6 weeks, 2 millimeters, those are strong reasons to repair. Swelling going down can unmask problems. Surgical incision insight. The transconjunctival approach inside the eyelid generally has the fewest complications, no visible scar. Might need a small cut at the side, a lateral canthotomy, the subciliary just below the lashes, higher risk of the eyelid pulling down, ectropion. Many surgeons avoid it now. Subtarsal, a bit lower down, gives good access, lower revision rate maybe?
Once you're in, what materials do you use to rebuild the floor? So many options.
Yeah, no single best answer. Autologous bone, like from the skull, is great biocompatibility-wise, but you have donor site issues. Resorbable alloplast, PLLA, PGA, they give support, then disappear. Good for kids, maybe, avoiding growth restriction concerns. Permanent alloplast, porous polyethylene, titanium mesh, give rigid support, but maybe slightly higher infection risk. Whatever you use, always do a force duction test after placing the implant. Make sure you haven't accidentally trapped anything before you close. And a pediatric pearl. Kids' bones are more elastic, makes those trapdoor fractures more common, and that oculocardiac reflex is much stronger. While entrapment needs early surgery, remember, many pediatric orbital fractures without entrapment and ophthalmos or dystopia can actually be managed conservatively. Complications after repair. Most common are persistent diplopia, infraorbital nerve issues, and ophthalmos, serious but rare. Optic nerve injury, blindness, retrobulbar hematoma, that last one needs immediate decompression.
Okay, let's talk zygoma, that cheekbone. Key to facial contour. What do residents need to know about its structure, that quadrupod in assessment?
Right, it's often called a tripod, but it's really a quadrupod structure. Provides that crucial support for midface width, cheek projection, orbital volume, muscles of mastication attached there too. Assessment. Look for a widened face, flattened cheekbone, bruising around the eye, palpable steps along the rim, trouble opening the mouth, trismus, and numbness in the infraorbital nerve area. Resident takeaway. Meticulous eye exam is crucial again, especially visual fields, pupils, red color perception. Rule out optic nerve injury.
Imaging. Still CT.
Absolutely. High-res CT, 1-2 millimeter slices, often with 3D reconstructions. Essential. Timing. Usually within 1-2 weeks for adults, maybe within 1 week for kids. Let swelling settle, but operate before things heal in the wrong place. Urgent repair. Only for muscle entrapment, optic nerve compromise, or major bleeding.
Lots of ways to approach the zygoma surgically. How do you choose? Balance exposure with morbidity.
It's a range. Close reduction with hooks or screws. It's an option, but controversial, lack of direct vision. Open approaches. Through the mouth, gingivobuccal sulcus, lower eyelid incisions, transconjunctival preferred for cosmetics, upper eyelid crease, or for high-energy smashes, the coronal approach. Wide exposure, but significant risks, facial nerve, temporal hollowing. Now here's a really key surgical insight for reduction. The zygoma has several points of contact, but the savino-zygomatic suture deep in the orbit is the longest and most reliable indicator of proper reduction. Reduce that first, get it perfect, and the rest often falls into place. Miss it, and you get poor aesthetic and functional results, including orbital volume changes.
And fixation, how many plates, how big?
Controversial. Depends on displacement, comminution. Plate size, 1.0 to 2.0 millimeters usually. Bigger is stronger but more palpable. Simple fractures, maybe just one plate at the zygomatico-maxillary buttress through the mouth might be enough. More severe. 2 or 3 point fixation is common. If you do a coronal approach for a high-energy injury, plate the zygomatic arch first before the other buttresses. Make sure that arch segment is flattened, avoid widening the face. Resident takeaway. After you stabilize the zygoma, always recheck the orbital floor. Fix any defects 1 centimeter bars are causing motility issues or in ophthalmos. Prefabricated titanium mesh works well here.
And soft tissue management, again, critical for the final look.
Precisely. Secure that zygomatic periosteum back to the orbital rim. If you did a lateral canthotomy, meticulously re-anchor that tendon. Right height, right depth. Maybe use a temporary frost suture in the lower lid if you had extensive access. Helps prevent malposition. Complications to know: vision problems, hematoma, implant pressure, persistent diplopia, anophthalmos, undercorrection, fat atrophy, graft resorption, infraorbital numbness, common, usually improves, lid malposition, and sometimes plates need removing later infection, exposure, palpability.
All right, from the cheekbone down to the foundation, the mandible, different forces at play here. Restoring that bite is paramount.
You hit the nail on the head. The mandible, that strong U-shape, thick bone, but prone to fracture. You've got opposing muscle forces, mastication muscles pulling up posteriorly, suprahyoids pulling down anteriorly. It creates distinct displacement. Mandible fractures, super common, especially young men, 25-34, often assault MVCs, and they are the most common reason for surgical fixation of facial fractures overall.
Immediate signs.
Yeah.
What do you look for? What imaging?
The classic complaint: my teeth don't fit together. Also, look for pain, swelling, trismus, tenderness, step-offs, numbness in the lower lip that's inferior alveolar nerve injury. Imaging. Panorex and PA films are key traditionally, but CT is often preferred now, especially in trauma. Better for posterior fractures, rules out other things.
Do you always rush these to the OR?
Ideally, yeah, for patient comfort, get them eating sooner. But interestingly, the sources suggest delaying beyond 72 hours doesn't significantly bump up infection rates, so you have some wiggle room if other injuries are more critical. Resident takeaway. Prophylactic antibiotics are standard for open fractures that includes any fracture in a tooth-bearing area and pre-op for everyone. Penicillin or clindamycin for allergies are common choices, though the best evidence for typodose is a bit limited.
Okay, main principle, restoring occlusion. How do we achieve that surgically?
It is absolutely the main principle. Restore the pre-injury bite. Reduce the fragments anatomically. Hold them still until they heal. We aim for early exposure, anatomical reduction, rigid fixation, early movement, those AO principles. Fixation options: MMF, wiring the jaw shut, mainly for condyle fractures now. Arch bars or MMF screws. Screws are cleaner, maybe loosen faster. Open surgical fixation. Ranges from truly rigid fixation, big locking plates, primary bone healing, to functionally stable fixation minute plates, allows some microscopic motions, secondary callus healing. Choice depends on the patient, the fracture, your experience. Let's quickly hit specific patterns. Isolated tooth-bearing fractures, symphysis, body, access through the mouth, watch the metal nerve. Often needs a small 2 millimeter plate below the tooth roots, maybe an arch bar. Functionally stable. Lag screws, often for symphysis or oblique body, but tricky.
Mandibular angle fractures, they have a reputation, right? High complication rate.
They certainly do, especially with a wisdom tooth in the line of fracture. Non-commended ones. Often a single 2 millimeter minute plate on the top border, Champy technique. Functionally stable. Want rigid. Add a second plate on the bottom border. Bilateral fractures. More unstable. At least one side needs more rigid fixation, maybe a heavier plate. Commended fractures, bone gaps. Need load-bearing fixation. Big plates that bridge the smash zone, fixed rigidly to good bone on either side. Bone missing. Reconstruction plate bridges the gap. Plan for bone grafting later, maybe delayed if it's dirty.
Condylar and subcondylar fractures. Lots of debate there, too.
Huge debate. They're common, 25–35% of mandible fractures. Treat closed, MMF for 2–3 weeks, then PT for minimally displaced ones. Or open, prevents height loss but risks facial nerve. Really depends on surgeon skill. Fracture displacement. Edentulous fractures. Often older patients, other health issues. Less precise reduction might be okay. Often need heavier load-bearing plates for immediate stability. Fewer complications. Complications. Check that occlusion meticulously in the OR. Malocclusion post-op often means reoperating. Early infections, washout, antibiotics, late infections, often bad fixation. Needs debridement, hardware removal, probably Biggle plates.
Okay, we've covered a lot of bone work, but sometimes the needle is your best friend.
Yeah.
Right. Let's talk about blocking the face. Essential skill for residents.
Oh, absolutely. Regional blocks are a fantastic tool. Less overall pain than sticking the patient multiple times with local. Use less anesthetic volume, less gets absorbed systemically. It's efficient. Clinical Pearl, a good anesthetic mix. Bupivacaine for duration, epinephrine for vasoconstriction, bicarb to reduce sting and speed onset, and maybe hyaluronidase to help it spread.
Okay, hit us with the high-yield blocks, the ones residents really need to know.
Right, 8 essentials. Infraorbital block, great for upper lip, side of the nose, lower eyelid. Mental plus block, chin, lower lip, essential. Up top, supratrochlear, supraorbital block, forehead, scalp flaps, critical. Dorsal nasal block, good for nasal reconstruction, setting nasal fractures laterally. Zygomaticotemporal and zygomaticofacial blocks. Cheek, temporal area. Great auricular block, fantastic for the ear, preauricular area, even ear cartilage donor sites. And for bigger mandibular work, the V3 nerve block, mandibular nerve, gives widespread anesthesia down there. Each one is a targeted, effective way to manage pain.
Wow, that was a huge amount of information, craniofacial trauma from top to bottom, but so much of it connects. As we wrap up, what are the big overarching principles that tie this all together for residents in the OR studying for boards?
Yeah, it's a lot, but there are core principles. When you're facing facial fractures, always think. 1, systematic assessment. Never just treat the face. Look for other injuries, head to toe, multidisciplinary team. 2, imaging is your guide. High-res CT, 3D reconstructions. Absolutely invaluable for understanding the breaks and planning the fix. 3, timing matters, but stability is king. Early repair is often good, prevents issues like chronic double vision, but getting a stable anatomical reduction is paramount. Don't rush into a bad reduction. 4, preserve function and de-aesthetics. Every choice incision implant material has to balance restoring the bite, the skeletal support, with minimizing harm and getting the best cosmetic result. It's a balancing act. 5, anticipate complications. Know what can go wrong for each area. Plan to prevent it. Recognize it early. Post-op CTs, careful eye checks, whatever it takes. And finally, 6, individualized treatment. No single recipe works for everyone. Tailor your plan to the patient, the specific fracture, and honestly, your own growing expertise.
We really have taken a deep dive today, from the frontal sinus down to the mandible, breaking down diagnosis, surgery, patient care.
So what's the bottom line for you, the aspiring plastic surgeon?
Yeah, the details for each fracture are vast, but the core idea, it's constant. Understand the anatomy, plan meticulously, execute skillfully. It's not just about fixing bones, it's really about restoring identity, function, confidence for your patients.
And as you think about all this, maybe consider, how might things like intraoperative imaging, navigation systems, how might they change things? Could they help us get even more perfect reductions, maybe make some of these big exposures less invasive down the road? What role will you play in shaping that next frontier? Keep diving deep, keep learning, keep asking those critical questions. Until next time.